we have started our general surgery portion. We have already discussed burns, shock, and hemorrhage. Now we will continue from blood transfusions. Okay, so what are the important things that we have to learn? That is different blood products and its uses, various blood products, indications for transfusions of each product, complications of blood transfusions, management, prevention of complications, and define massive blood transfusions and what are the risk factors. So, starting from indications of blood transfusions, what are the indications? The surgical indications, there are pre-operative indications, there are post-operative indications, there are indications in severe burns and in bleeding disorders. In surgical indication, when there is accidental hemorrhage, when there is hemorrhage from GIT tumors, when there is ulcerative colitis, when there is bleeding per peptic ulcer, and when there is hemorrhage, there is indication of blood transfusion. In pre-operative case, when the HB amount is less than 8 gram, then transfusion is indicated. Transfusion pre-operatively. Post-operatively, if become anemic due to infection or hemorrhage, reactionary or secondary blood should be transfused. In severe burns, must blood transfusion is done, and in bleeding disorders, transfusion is done in thrombocytopenia and hemophilia. So there are basically 5 indications for blood transfusion during surgical, preoperative, postoperative, in severe burns, and in bleeding disorders. Now, what are the different blood products and its uses? And specific indications for transfusion of different blood components. The blood components are cells and plasma. In cells, there are packed red cells and platelets. Packed red cells are indicated in severe anemia, in small children, in elderly patients, in whom introduction of large volume may cause volume overload. So, if there is large amount of volume already present, so only packed red cells are transfused. Platelet can store at 22 degrees C for 5 to 7 days and indicated in thrombocytopenia, that is bleeding disorder. The second part of blood is plasma, and it is removed after centrifusion of whole blood. It consists of purified protein fraction, fresh frozen plasma. In the purified protein fraction, plasma rich in protein suitable for replacement of proteins. For example, after burn can store for several months under 4 degrees C. Purified protein is separated from plasma, and it is rich in protein, and it is suitable for the replacement of protein. Fresh frozen plasma. Plasma obtained from fresh blood is rapidly frozen and stored at -40 degrees C to -50 degrees C. It is good source of clotting factors. Used for patients with abnormal coagulation, severe renal failure, clotting factors deficiency, Christmas disease, and hemophilia. Fresh frozen plasma contain a lot of clotting factors, so it is transfused when there is clotting factor defects, that is hemophilia, Christmas disease, and severe renal failure, abnormal coagulation. Third one is cryoprecipitate, which is rich source of factor 8, stored at -40 degrees C and readily available for patients with hemophilia A, and it is used in DIC, disseminated intravascular coagulation. Fourth one is fibrinogen. It is used in severe dilution of fibrinogen like DIC. SAG mannitol blood. In this process, all plasma is removed and is replaced by 100 ml of crystalloid solution contains sodium chloride, adenine, anhydrous glucose, and mannitol, and it contains no protein, and it is good for anemia. Now, prevention of complications or safety measures during transfusions. Positive indication of patient at bedside along with hospital administration number. Comparison of name of patient and blood group written on blood bag with slip provided by blood bank. Checking of ABO and RH group compatibility of each bag with patient. Examination of each bag for evidence of damage. If in doubt, not use blood and return it. Cross matching. Check vitals before transfusion. 40 drops per minute can transfer rapidly in severe blood loss. Blood transfusions notes should be mentioned, which include vitals, blood bag number, date and time of transfusion, and reaction occur. Immediately stop transfusion if any reaction is noted. Observation should be at least for 15 minutes. Emergency medicine should be in hand at time of transfusion. Screening for HPV, HCV, and HIV is necessary. Screening for CMV also recommended in special circumstances. Blood donor should be fit with no evidence of any active infection. Complications of transfusions. What are the complications of transfusions? First one is transfusion reaction. Acute immune hemolytic reaction occurs when donor and recipient blood do not match. Patient body release antibodies cause hemolysis of RBCs, releasing harmful substances into bloodstream caused by IgG antibodies, leading to rigors, lumbar pain, dyspnea, hypotension, and hemoglobinuria. Stop transfusion urine output measure should be 100 ml per hour. If hemolytic reaction occurs, then you should stop the transfusion. The second one is delayed hemolytic reaction. Occurs when body slowly attack antigens other than ABO antigens. Allergic reactions, febrile reactions, graft versus host disease, transfusions related acute injury, overloading, air embolism, transmission of disease, potassium toxicity, citrate toxicity, metabolic acidosis, hypothermia, hyperammonia, thrombophlebitis, bleeding diathesis. These are the complications of blood transfusions. Okay, what is massive blood transfusion? Replacement of patient total blood volume in less than 24 hours or as acute administration of more than half of patient estimated blood volume per hour is called massive blood transfusion. What is massive blood transfusion? When the patient blood is replaced in less than 24 hours or as acute administration of more than half of patient's estimated blood volume per hour is called massive blood transfusion. What are the risk factors? Dilutional thrombocytopenia, coagulation factor depletion, especially factor 5 and factor 8, oxygen affinity decreases, hypocalcemia may occur, hyperkalemia occur, metabolic acidosis due to citrate, and acute respiratory distress syndrome. Okay, we have discussed the complications of blood transfusion and what is massive blood transfusion, what is transfusion reaction, incompatibility, hemolytic transfusion reaction, febrile transfusion reactions, and allergic reactions. These are the transfusion reactions. What infections can occur? Bacterial hepatitis, HIV, malaria, air embolism, hyperkalemia, thrombophlebitis, metabolic acidosis, transfusion related acute lung injury, and congestive cardiac failure. These are some of the complications of blood transfusions. Now, how we will manage the transfusion reaction? The signs and symptoms of transfusion reaction are fever, chills, tachycardia, hyper or hypotension, collapse, rigors, flushing, urticaria, bone muscle and abdomen pain, shortness of breath, nausea, malaise, respiratory distress. Now, management. First of all, stop the transfusion reaction, then measure vitals, that is pulse, temperature, BP, oxygen saturation, then check identity of recipient details on unit and compatibility form. Check for fever, check for urticaria, mild allergic reaction, give anti-allergens, and restart transfusion slowly. Mild fever, give paracetamol, restart transfusion and observe. ABO incompatibility, take down unit and giving set, return to blood bank. Monitor urine output, catheterize, maintain urine output at greater than 100 ml per hour. Furosemide if output fail. Give furosemide if output fails. Treat only DIC with appropriate blood components. Inform hospital department immediately. Severe allergic reaction, bronchospasm, angioedema, and abdominal pain. Then return the blood. Give anti-allergen and give O2. Give salbutamol and nebulizers. Adrenaline for severe hypotension. Other hemolytic reaction, give broad spectrum antibiotic, and during acute dyspnea or hypotension, transfusion related acute lung injury, give 100% of oxygen saturation, treat as acute respiratory distress, for fluid overload, give O2 and furosemide. So this was our blood transfusion chapter. Let's revise what we have studied. First of all, we have discussed definition of blood transfusion, the indications of blood transfusions, which are surgical, preoperative, postoperative, severe burns, and bleeding disorders. Then we discussed the different blood products, which are cells and packed red cells and plasma. In cells, we have packed red cells and platelets, and in plasma, we have purified protein fraction, fresh frozen plasma, cryoprecipitate, fibrinogen, SAG mannitol blood. Now, prevention of complication or safety measures during transfusion. These are the safety measures which should be taken while while doing the transfusion of blood. What complications can occur due to blood transfusions? These are transfusion reactions are acute immune hemolytic reactions, delayed hemolytic reaction, non-immune hemolytic transfusions, allergic reactions, febrile reactions, graft versus host disease, transfusions related acute lung injury, overloading and CCF, air embolism, transmission of disease, potassium toxicity, citrate toxicity, metabolic acidosis, hypothermia, hyperammonia, thrombophlebitis, bleeding diathesis. These are the complications. What is massive blood transfusion and what are its risk factors? Then we discuss the management of transfusion reaction or how to manage the complications that occur due to the transfusion reactions. Stop transfusion reaction, measure the vitals, check identity of recipient, check for fever, urticaria, mild fever, check for ABO incompatibility and severe allergic reaction and other hemolytic reaction and acute dyspnea or hypotension. And each reaction or each complication that occur due to blood transfusion is treating accordingly. ATLS, that is Advanced Trauma Life Support. We will discuss this chapter and the main topics in this are categories of different injuries and what is management. What is triage? Triage is process of determining priority of patient's treatment based on severity of their condition. There are many schemes of triage and a common scheme are given below. What is triage? Whenever we have a patient and what are the important treatments and what we should give the priority, that is triage. Now there is triage sieve and triage sort. Triage sieve is a quick survey in which is made to separate the dead and walking from injured. Triage sort is remaining casualties are now assessed and allocated to 3 or 4 groups. First of all, what is done? The dead patients are separated from walking and injured patients. Then in the triage sort, the remaining casualties are now assessed and allocated to 3 or 4 groups. Category 1 labeled as red, which is critical and can't wait. Category 2 is labeled as yellow, which is urgent, serious injury but can wait for short term. In category 3, which is labeled as green, less serious injuries, not can delay. Okay, category 3 patients can delay. Category 4 are labeled as black, expectant, severe multisystem injury. Survival is not likely. Care should not be abundant. Spare any remaining time and resources after immediate and delayed patients have been treated. Category 1, 2, 3, 4. Now, what is ATLS? ATLS stands for Advanced Trauma Life Support. It contains of primary survey, secondary survey and tertiary survey, which is definitive care. Primary survey. In primary survey, we have A, B, C, D and E. For A is airway and cervical spine immobilization. For B, we have breathing and ventilation. For C, we have circulation and hemorrhage control. For D, we have disability or neurological evaluation. For E, we have exposure plus environmental control. Now, airway and cervical spine immobilization. Suctioning of nasopharyngeal airway, chin lift, jaw thrust. These are the methods which are used for airway and cervical spine immobilization. Advanced methods are endotracheal intubation, cricothyroidectomy, and tracheostomy. Prevention of cervical spine injury, we have immobilized patients, avoid hypertension of neck, hyperextension of neck, and apply cervical collars. This was the airway and cervical spine immobilization. Now, breathing ventilation. First of all, expose the chest and assess respiration rate and type. Then give O2 inhalation. Then check chest wall, lung, and diaphragm by inspection, palpation, percussion, and auscultation. Then do pulse oximetry. Look for life-threatening condition that impairs ventilation. That is tension pneumothorax, massive pneumothorax, flail chest, open pneumothorax, pulmonary contusion, rib fractures. Any assisted ventilation needed or not. Tension pneumothorax. Wide bore cannula followed by chest intubation in fifth intercostal space. Massive hemothorax require vigorous circulations followed by chest intubation. Flail chest managed by positive pressure ventilation. For cardiac tamponade, needle periocardiocentesis may be life-saving in short term. thoracotomy and repair is required for definitive management. This was the management for breathing or ventilation. If any assisted ventilation needed, that is in case of tension pneumothorax, wide bore cannula is used. In massive hemothorax requires vigorous circulation. In flat chest, managed by positive pressure ventilation. For cardiac tamponade, needle pericardiocentesis is needed. These are the specific measures which are needed in the case of any assisted ventilation. Now coming towards circulation, look for signs of shock. Then skin color, whether it is pallor, narrow pulse pressure, low level of consciousness is checked, hypotension, tachycardia, and diminished urine output. Control hemorrhage. Apply direct pressure. Control hemorrhage. Apply direct pressure. Pneumatic splinting devices. Assess need for surgical intervention. Now, fluid replacement therapy. Double intravenous line should be maintained. Adults given 2-liter bolus fluid, ring elected. For children given 20 ml per kg bolus fluid. If there is disability or dysfunction of the CNS, it is treated. Rapid neurological examination is done by AVPU method. That is A, alertness, V, voice response, P, pen response, and U is unresponsiveness. Raised intracranial pressure should be ruled out. Exposure and environmental support. Undress patient completely, use trauma seizure, prevent hypothermia by warm blanket and warm fluids, early hemorrhagic control, warm room temperature maintained. So this was the primary survey. What we have discussed in the primary survey, we have ABCDE, that is airway and cervical spine immobilization, breathing or ventilation, for C circulation, for D disability, and for E exposure and environmental support. Now coming towards secondary survey. It is done after primary survey. Patient is resuscitated, vitals are stable. It includes complete history, complete head to toe examination, reassessment of vital signs, complete neurological examination, specific procedure, specific lab investigations. Complete history. For complete history, remember the mnemonic AMPLE. Allergies. A for allergies, M for medications, P for past illness, L for last meal, and E for events or environment or mechanism of injury. You should ask the history, and all the history of these major things should be taken. The first one is head to toe examination. After taking history, you will go for head to toe examination. In head, visual acuity, pupil size, conjunctival hemorrhage, penetrating injury, contact lenses. If contact lenses are present, remove it. Dislocation of lens, ocular entrapment, bleeding from head. Maxillofacial structure, palpate all bony structures. Intraoral examination, assessment of soft tissues, trauma not related to airway or bleeding can be delayed. Cervical, spine, and neck. Patient with head trauma or maxillofacial trauma should be presumed to have unstable cervical injury. Neck should be immobilized immediately until investigated. Cervical spine tenderness, subcutaneous emphysema, tracheal deviation, and laryngeal fractures are penetrating injuries should be seen during examination of neck. In chest, thorough examination of chest wall to rule out open tension pneumothorax, hemothorax, flail chest, or contusions. In abdomen, to note any intra-abdominal injury and dealt aggressively. In perineum, rectum, and vagina examination, perineum for contusion, laceration, hematoma, and urethral bleeding, rectum for bleed in bowel, lumen, pelvic fractures or high riding prostate, and vagina for any injury. Musculoskeletal system is examined. Extremities must be inspected for contusion and lacerations. Bones should be palpated and movement of joint should be checked. Assessment of peripheral pulses should be done for vascular injuries. Reassessment of vital signs done by clinical assessment, monitoring of respiratory rate, blood pressure, arterial blood gases, review of diagnostic results. I have written this mnemonic and now I don't remember what is this. Review of diagnostic results, use of analgesia. Complete neurological examination is done Glasgow Coma Scale, CNS examination, deterioration, and improvement in Glasgow Coma Scale. Specific procedures or lab investigations are done in secondary survey, done after history and examination. For suspected cervical spine injury, X-ray should be done as lateral view, additional X-ray extremities, spine, anterior-posterior view, CT scan, contrast X-ray, urography, angiography, and endoscopy. What is a tertiary survey? After the secondary survey, we will go to tertiary survey. It contains definitive care and support. Patient shifted to ICU, OT, or others, respectively, according to need of patient, and definitive treatment is planned. Tertiary survey is defined as patient's evaluation that identifies only injuries after initial resuscitation and operative interventions. Patient is more aware. More information about mode of injury by patient is gathered. Trinodal death pattern. Immediate death, death occurring within first few minutes of injury. Early death, 30% death after few hours of injury, and late death is defined as due to sepsis or organ failure. Exam note. Questions management, history examination, investigation and treatment. Questions treatment. Okay, these are important to learn for exams, that is management, history examination, investigation and treatment. Okay, so what we have discussed in advanced trauma life support, let's learn the review. Okay, this is ATLS Trauma Life Support. We have learned what is triage, CU, which is triage short. In triage short, we have 4 categories 1, 2, 3, and 4. According to these categories, the patient is labeled. Then what is ATLS? It is Advanced Trauma Life Support. It consists of 3 surveys, that is primary, secondary and tertiary survey. In primary survey, we have ABCDE, that is airway and cervical spine immobilization. We have advanced methods. We have prevention of cervical spine injury. We have breathing or ventilation support, circulation, blood replacement therapy, disability exposure, environmental support. In secondary survey, first we will take the history, then we will do the examination. Examination is from head to toe examination. First we will examine the head, then maxillofacial structures, then cervical spine and neck, then chest, then abdomen, then perineum, rectum and vagina, then musculoskeletal system, then reassessment of vital signs is done. Complete neurological examination is done. Specific procedure or lab investigations are done. In tertiary survey, definitive care and support is provided, and the patient is treated with definitive care and support. Then we define the trimodal death pattern. It consists of immediate death, which is 50% and occur within first few minutes of injury. That is immediate death, the early death which occur in the first few hours of injury, and the late death which occur in the due to sepsis or organ failure. The next topic we will be discussing is aseptic technique and sterilization.